This is 100 million women worldwide. This is not a number to be ignored. And it is the leading cause, the number one cause of ovulatory infertility. Hey, welcome back to another episode of Better with Dr. Stephanie. It's me, your host, Dr. Stephanie Estima. And this week we are continuing on my little mini lecture series. And when I say mini, I mean huge lecture series on why fasting is different for women. So if you missed last week, please go back and listen to that episode. We are continuing this week with a deep dive into some of the very typical hormonal presentations that I see in practice, that I help other coaches to care for other women in their practices. And this is as I mentioned, a continuation of my presentation that I was asked to present to with Oxford University. And this part, as I was mentioning last week, I totally over-prepared for this series, and I put in so much information. I only had, I think it was 25 or 35 minutes that I had to present to some of these researchers and professors and doctors, et cetera. So this is the part of the lecture that I didn't get to present to them. So this is kind of a bonus for you as well. So if you are watching this on my YouTube channel, you are about to see me share my screen effortlessly and not have any problems whatsoever, because that would never happen to me. So we left off last week talking a little bit about how your period starts in your brain. And I'll just remind you again, I'm picking up exactly where I left off from last week's episode. So if this is not making any sense to you, go back and listen to last week's so that you can get the context for this week. So your period starts in your brain, essentially, right? It starts in the hypothalamus, where we release follicular stimulating hormone and luteinizing hormone. And this is particularly important for our women with PCOS, because we can clinically see a very high ratio of luteinizing hormone to follicular stimulating hormone. So normally, if you want to understand, if you suspect that you might have PCOS, let's say, it would behoove you, let's say, and your functional medicine practitioner or your allopathic physician, whoever you're working with, to test those ratios. So the best time to test LH and FSH, where we want to get that 1-to-1 ratio, which what would be considered normal, is day 2 or 3 of your menstrual cycle. So day 2 or 3 of your bleed week is where we want to be measuring. So women with polycystic ovary syndrome, we can have marked, we'll say, luteinizing hormone elevation levels in this time period, where we can see levels rising 2 to 3 times that of follicular stimulating hormones. This is a really good time to catch it. And there are many reasons. One of the reasons is usually that insulin levels in the body are too high. So if your insulin levels if you have this sort of state of hyperinsulinemia, this can elevate luteinizing hormone. Another reason, which we won't necessarily go into now, is hyperprolactinemia, meaning that the levels of prolactin are too high as well. They're also causing a surge in luteinizing hormone. And if you know anything about the menstrual cycle, we know that the luteinizing hormone is very, very important right before ovulation. It is what actually gets the follicle to release the primary follicle that is developed under estrogen's influence, or more accurately, estradiol's influence. We have this elevated level of estradiol for somewhere between 40 to 50 hours, starting at about day 10 of your cycle. And then following that, we have about a 10-hour elevation, this major surge in luteinizing hormone. So if you are already at a 2 to 3 times, elevated above baseline level of luteinizing hormone, you're not going to get much of a surge, right? And it's the surge, it's the differential between baseline and the apex of that curve that is going to cause the follicle to release that egg. Now, with polycystic ovary syndrome, and this is, obviously like a podcast and a book, several books unto itself, we see a lot of other contributing factors to PCOS. One of them, and I teach this in my Estima certification program to my practitioners and health coaches, is that we see genetically, there does seem to be some genetic component to PCOS, in that we see, in particular, we see the gene that converts testosterone to dihydrotestosterone, which is, a layman's term might be like super testosterone, right? Like DHT, or dihydrotestosterone, is about 6 to 7 times more potent than your regular run-of-the-mill testosterone. And we see with women with PCOS that there is, this like almost 1,000-fold increase, in some cases, thousands of folds of increase in activity of this 5-alpha reductase activity. So the gene itself, for those of you that want to know, is SRD5A2. And we see that upregulation in the ovarian follicle in women with PCOS. And then, of course, the metabolites of SRD5A2 also, little rascals, act as inhibitors of aromatase, which is the CYP19A1 gene, which is basically the gene that's involved in the testosterone to estrogen conversion. And of course, those two things, you're getting testosterone converted into dihydrotestosterone, that's super testosterone, and an inhibition of estrogen production from testosterone. So estrogen is created from testosterone. We have these two pathogenicities, let's say, that contribute to the clinical picture, and of course the physiological abnormalities of PCOS. So when we think about a woman who has, or if you're a woman, let's say, where you have, some of the classic textbook signs of PCOS are going to be thinning hair at the temples. Okay. So that's one thing. We'll often see some thickening, we'll say, or like very thick, wiry hairs at the chin and kind of along the hormonal area of the face, which is like the lower half of the face. You may also see like chest hair, back hair on a woman where we wouldn't normally see it. In that way, because we have this like testosteronization, let's say, of this woman, where there's an excess amount of testosterone, rather, her body will start to behave more male. And so we will see this sort of male pattern baldness, more hair on the face, chest, and back. You might also even see like ectopic fat distribution, meaning that she's going to start putting on adipose tissue or fat in a manner consistent with the way that a male might put on excess adipose tissue as well, which is kind of through the central region, like through the belly. We often call it like the spare tire, let's say. I hate that word, but just for kind of a visual, like sort of like a thickening through the midline. From a, body morphology, like kind of perspective, she's more of an apple than she is a pear. Okay. So someone who is a bit hip heavy, like that's me, right? I got hips and a booty and I have some to spare. You might call my body type more of a pear, right? Kind of like heavier on the bottom, let's say. This is like, I'm making sweeping generalizations right now, but just as a visual. Okay. So someone who has PCOS and who's had it for a long time and it's gone underdiagnosed or untreated or whatever, we may see that excess adiposity through like that centralized deposition of fat, giving her a less of a waist and more of that apple type of presentation. Okay. So, we're going to talk a little bit, we've talked a lot about, insulin reduction, and insulin resistance. I talked a lot about that in the last podcast. But moving on into, kind of some of the frustrations that a woman with PCOS, might have. Like one, obviously, is that having this pathogenicity, right? Having this kind of, presentation of like excess testosterones and like the dihydrotestosterones, inhibition of aromatase activity. The net here is that the ovarian follicles fail to reach ovulation. Okay. It causes a delay in ovulation, right? Which then, will cause irregular periods, absent periods, non-existent periods. I think I mentioned this last time that this is 100 million women worldwide. This is not a number to be ignored. Okay. This is the most common endocrine disruption, this endocrine disorder of women, in reproductive age. And it is the leading cause, the number one cause of ovulatory infertility. Okay. Now, I won't get into, I will get into it a little bit. I have a problem with many words. As a word nerd, the name PCOS, squeak of a misnomer. Not all women have cysts on their ovaries. Okay. So about 20% of women who do not qualify for the diagnosis of PCOS actually have these so-called cysts, right? And 30% of women who have PCOS do not exhibit these cysts. And even more accurately, these are not really cysts. Like this is like, it's not like a pustule, let's say, or like like an acne breakout. These are actually follicles that have not gone through the maturation process. Of course, the biggest frustration for a woman with PCOS obviously is her fertility. This becomes particularly important for her if she decides that she wants to have children. Obviously, I remember for myself, like I was like, don't want them, don't want them, don't want them, don't want them. Oh my God, I really want kids. It was like a light switch all of a sudden. I couldn't stop staring at babies in parks and noticing children everywhere. And it was just like basically my biology telling me that, yeah, like you're ready now. Like it's time. And for a woman who, I was lucky enough to be, pregnant in my second month of trying. But the first month when I got my period, I was devastated. Okay. So I cannot imagine, and I won't pretend to imagine what it's like to go 4 months, 6 months, 9 months, 1 year, without success. That is a very long time for someone who wants to be pregnant. That is by far the biggest challenge is their fertility. And even if you don't care about having children, if that is not in the cards for you as a woman, it is one of your vital signs, one of blood pressure and oxygen saturation and heart rate and respiratory rate. So is the optimal cycling and optimization in general broadly of your menstrual cycle. So as it relates to intermittent fasting, which is what this lecture series is all about, fasting is very well tolerated for my women with PCOS. And in fact, it's actually one of my most favorite tools to use with my ladies who I am suspecting or I have confirmed that they have some degree of polycystic ovary syndrome. So how does that look? Well, last week I was talking a little bit about some of the different types of fast. So the non-caloric liquid fast and the caloric liquid fast and calorie restriction. There's a lot of different ways to, what's the saying? A lot of different ways to skin a cat, I think. It's such a different and very disturbing visual, but there's a lot of different ways to do it. I personally, depending on the severity of the case and depending on, is she trying to get pregnant, we will, and if we can kind of figure out at where she is generally in her cycle, I am going to very quickly try and build up a fasting tolerance in this woman, meaning that we are going to be doing a minimum of 12 hours of fasting every single day. But the idea is to ramp that up as quickly as we can. So as quickly as I can, I'm going to try to get her on a 16-8, so a 16-hour fast, an 8-hour eating window, and ideally with a night limiter, meaning that she is going to eat, let's say within 8 hours, but she's going to finish eating 2 to 3 hours before her bedtime. So that means that she might start eating earlier in the day, which is a little bit opposite to what I find currently, kind of exists in the fasting culture. A lot of people who practice intermittent fasting, if they're doing like a 16-8, let's say, they try to delay their eating until, if it's a 16-8, it might be they'll delay their eating until noon, and then they'll eat if over that course of that 8 hours, like 12 to 8 p.m., and then go to sleep. I find 8 p.m. Just a squeak late to be having your last meal, because 2-hour clearance is 10 o'clock in the evening, 3-hour clearance, which is better, is 11. And that's right around the time when most of us at least should be going to bed. I mean, I'm kind of a 9 p.m. kind of girl. These days, I love going to bed at about 9:30. It's like, whew, what a day. I'm in my, doing my oils in the evening and my creams and all the stuff. So for a woman with PCOS, as quickly, and again, this is all dependent on the individual, right? But, as quickly as I can get her up to a 16-8. And if it's a very severe case, I'm going to get her to be doing like 24-hour fast, 36 and 48-hour fasts as quickly and as often as she can tolerate that. So that might be once a week. If we're talking about a morbidly obese patient, someone who also has a lot of weight to lose, we might do that several times a week as well. Okay, so kind of just summarizing this. So if you're watching this on YouTube, you're going to see this really great illustration here where we're looking at sort of the clinical picture of PCOS is a hallmark. There's some hallmark features here: insulin resistance, which we talked about last week; dyslipidemia, where we have an elevation of lipids, which are not ideal. We may have a diet that's not necessarily well suited for her. And that all leads to this kind of systemic inflammation, which is going to lead to sort of poor oocyte quality, impaired ovulation, or absent ovulation altogether. So fasting, kind of as a summary, like where fasting fits in here, it is like, the Beyonce and Jay-Z, kind of perfect pairing. Like, individually they make really great music, and then together it's like, Crazy in Love and all the, the great music that they make. Fasting and PCOS is like a match made in heaven. It's like peanut butter and jelly, it's like they are very, very well suited. And often when we start to get a woman who has PCOS more metabolically healthy, one of the things that I do is actually start paring back the fasting, right? And you'll hear me say this over and again, probably until you're tired of me saying it, but we need to hear things many times, sometimes for them to kind of sink in. But the diet that you follow when you're unhealthy is not going to be the same diet that you do when you're healthy. Okay. So you may need to fast aggressively. Let's say if you have PCOS and you don't have a regular period, we might need to improve that FSH to LH ratio by fasting day 1, day 2, day 3, day 4 of your cycle, let's say. We may need to get you to start lifting weights so that you are a better glucose disposal agent, negating the need for those sort of high insulin outputs. And then, there are other things, of course, that we can add into that, like stress management and, all of that. But like fasting, we'll kind of keep it to fasting, and I'll throw in a little bit of exercise as well too, are very, very important for correcting this problem. Now, I will say one of the questions, interestingly, that I get, which I really think is a good question, it means you're paying attention. Sometimes I'll say something like lifting weights is one of the best things that you can do for PCOS because it makes you a better, as you grow your functional tissue, as you grow your, lean muscle mass, you are going to better control your insulin output. And the question that I get, and I've had this enough times that it's worth bringing up, is, well, isn't weightlifting going to make her testosterone worse? Because when she's lifting weights, we know that, as we build more tissue, we naturally will increase her testosterone. And the answer is that the effects that you are going to have, the adaptations that you have when you are resistance training specifically, and of course there can be cardio in there as well. And usually it's warranted with a woman with PCOS to be developing a program with a base of resistance training as well as cardiovascular work. But the amount of healthy adaptation that you're going to have. So the improvement in lipid control, the improvement in systemic inflammation. So the reduction in cytokines, the reduction in C-reactive protein. You'll see this like the TNF, like the tumor necrosis factor alpha, some of the reduction in prostaglandins. All of these things are going to be improved. So it is the net adaptation to resistance training is better for a woman with PCOS. And then, of course, not to mention that her ability to dispose of circulating glucose is going to be augmented when she has more muscle, which is, I've mentioned, is going to negate the load on the beta cells of the pancreas to continually be outputting insulin. So we don't have this like hyperinsulinemic state. I was talking last week about insulin resistance, and one of the first places, of course, that we see insulin resistance is, shocker, it's in the muscle. And it's not so much that that we can't actually it's not that we can't, what's happening is the cell is essentially starving. Like we can't actually pull we can't get the glucose into glycogen. So when we are resistance training, that improves insulin resistance almost from at the level of the myocyte almost immediately. So resistance training for a woman with PCOS, also very, very important. Okay, let's talk a little bit about estrogen dominance. This was my personal situation for many, many years. No longer the case, but it is the reason why the Betty Body exists and my whole story exists, is because of my own healing journey from what I thought was a curse for being a woman. But estrogen dominance is, well, I should say a better way to describe this is when we say estrogen dominance, it is unopposed estrogen relative to progesterone in the luteal phase of the menstrual cycle. So you can see nobody wants to say that, so we just say estrogen dominance. Okay. So for me, when I was dealing with this, it was like mood swings and depression around maybe sometimes I still do this, but I could watch a commercial like a day or two before I started bleeding, and it could be about like NyQuil and I would just be bawling. Okay. It didn't even have to be like an emotionally, like it wasn't trying to tug at, your heartstrings. I could be watching anything and I would be crying. So, mood swings, certainly depression. I used to be very sad around right before I got my cycle, right before I started bleeding. Weight gain for women with estrogen dominance, again, coming back to that morphology, we tend to pack on the pounds in the lower half of the body. So that would be kind of the lower stomach area, the hips, the thighs, the bum. Breast tenderness and swelling. So this was very much my story for years. I even wrote in the Betty Body book that I felt like my breasts were angry at me. Like they were just like, everything was hot. Everything was super hot. My rings, I had a hard time fitting, my wedding bands on my fingers, like, in the last week or so of my cycle. And then other things that many women will experience are things like vaginal dryness, either really heavy flow. That was also the case with me as well, excessive flow, or it could also be the opposite, like scanty blood flow. And then things like getting really, really hot in bed, night sweats, insomnia that you could kind of predict, like, okay, week 3 of my cycle, here we go. Like, I'm not going to sleep. Of course, if estrogen is going unopposed in the luteal phase of the cycle, you are going to have some changes in your sleep. Progesterone, which is what should be the dominant hormone, or we should see it in higher levels relative to estrogen, is actually what helps us sleep amazingly, because progesterone does activate GABA receptors in the brain, helps us chill out. It activates some of these inhibitory pathways that help us have some of the best sleep, let's say, of our life. So if you are estrogen dominant, you are going to have usually you can predict you'll have this sort of cyclic insomnia, and there'll be there's more symptoms, but this is kind of the gist of it. Like clinically, this is what a patient is going to be, or you might even see yourself in this picture as well. So when we think about how we might apply the fasting lens to this, for estrogen dominance in particular, if you have your sort of physician's hat on, let's say, you want to take a really hard look at the detoxification capacity of the liver. And when I say liver detox, like I don't mean like cayenne pepper and maple syrup and lemon drinks for 10 days on end. Like I'm not talking about I'm talking actually about the physiological process of detoxification. So there's 3 phases of liver detoxification. The first is called hydroxylation, which is essentially, and I should just say, kind of taking a 30,000 foot sort of view to detox. Detox is basically your liver and other, emunctories, taking a toxin, or in this case, a hormone, and setting it up to become more water soluble so that we can excrete it. Okay. So hydroxylation, for the nerds that really want to know, my beautiful nerds, we're just adding an OH group essentially to the thing that we are trying to get rid of. So in this case, with, let's say, estradiol, which is the most dominant hormone, we are going to either make it 2-hydroxyestradiol or 4-hydroxyestradiol. So we're adding, it's either going to go down a pathway called 2-OH estradiol or estrone, or 4-OH or 4-hydroxyestradiol or 4-hydroxy estrone. So we want to take a hard look at liver function. So let me finish that thought. So we had hydroxylation as phase 1. Phase 2 is conjugation, which is a combination of glucuronidation, glutathionization, and methylation. Those are just really big words. All that means is that we're just preparing it, packaging it up so that we can send it out to the appropriate, let's say, organ to get rid of it. So that might be throwing it to the gut and the microbiome. That might be excretion through the kidneys, or let's say emunctory, maybe you're sweating it out, something like that. Okay. So liver function and the process of detoxification. I mentioned excretion through the gut. So we want to be considering the health and well-being of the microbiome, and a particular subset of the microbiome called the estrobolome, and the ability to kind of clear some of the deconjugated, or the conjugated, I should say, estrogen, and not deconjugate it. So for women like this was me, gosh, forever. What really works well, I would say, from a clinical perspective here, and we're talking about fasting only, is usually a caloric fast. So what, I know that sounds like an oxymoron, a caloric fast. Some of the, fasting purists are like, I've lost them. They're like, nope. This is not a fast. This is not a fast. This is hearsay. So, but I disagree. I think that for women, we have to be very cognizant of some of the different hormonal presentations. A caloric liquid fast is appropriate, both in medium and long-term durations, kind of depending again on the severity. But when you are having, let's say, soups, bone broth soups, or even like I would make minestrone or chicken soups, that kind of thing. It is a model of caloric restriction, but you're still, if you're having, let's say, a bone broth soup, usually soups are really rich in glycine. They're really rich in collagen, and these are going to basically, and there are other components that are going to really help the amplification, let's say, of elimination. A lot of times with women who have estrogen dominance, they will also complain of like leaky gut. So a lot of sort of GI distress, let's say, that happens after eating. So they feel bloated, they feel distended, consuming things like collagen, things high in glycine. These often will help with the epithelial lining of the gut, which has a really high turnover. So you're over the course of time, let's say like a 1 or 2 or even a 3-day fast, you're helping that turnover of cells, and you're making the cells better and stronger. You're also going to help with your bowel movements, right? So the more liquid that you are going to be consuming, hopefully that's going to help with having a nice daily BM. Okay. So, if you're watching me on YouTube, we're going to move to more of this idea of chronic inflammation and chronic stress. So whenever I've presented anything around chronic inflammation and chronic stress to, let's say, a corporation, or I'm in front of a crowd, I'll usually say, I want you to raise your hand when you've heard 3 of these. I'm going to read off a list, And 100 times out of 100, I can't get through the full list without everybody in the room raising your hand. So we're going to play like a big collective game here, because we have tens of thousands of people who download this podcast every single week. And you all are going to raise your hands for me. Okay. So this is going to be kind of fun. So when you hear 3 things, if you're driving, obviously don't raise your hand, but, I just want you to kind of like mentally raise your hand when you've heard 3 things that describe you. Okay. So, and usually I get most of the hands go up after I read the first couple of them. So brain fog. If you've ever experienced brain fog, needing coffee in the morning to get you going. Energy dips through the day. So usually it's at like post lunch to kind of 3 p.m. time where we see if you're experiencing an energy dip, if you have difficulty falling asleep, difficulty maintaining sleep, weight loss resistance. So you have like an inability to lose weight no matter what you do, salt cravings, needing to snack or eat frequently. Moodiness is another one. And of course, so just from that list, like I haven't gotten through the whole thing yet, but how many, hopefully you've heard at least, not hopefully, I should say, it's with a high predictability. I'm going to guess that as I've read that list out to you, that you've been able to say, yeah, 2 or 3 of those are definitely me. And if those are not you, then congratulations, you are winning at life and you get a gold star on your chart because you're doing really well. But for the rest of us, most of these are very, very applicable to everyday life. And eventually, of course, what happens is when you have some of these symptoms like constant brain fog, needing coffee in the morning to get you going, energy dips kind of after lunch, difficulty falling asleep, difficulty maintaining sleep, weight loss resistance, needing to eat snack frequently, moodiness, salt cravings, all this stuff. Eventually, that affects your thyroid health as well, right? And of course, that change makes it even harder to lose weight. Whenever we see thyroid function starting to drop, things like cold hands, cold feet, like weight loss resistance. And then, we have like the classic outer third of the eyebrow, hair falling out in clumps, like all that kind of stuff. We start to see very, very heavy periods, very, very classic sign with women with hypo or low functioning thyroid. So in my clinical world, a woman is stressed in this way until proven otherwise. So I have a woman coming in who's complaining of weight loss resistance. She's tired. She's having trouble sleeping. Things aren't working for her in the way that they used to. It's like, all right, she's inflamed and stressed out until I can prove otherwise. I'm working on the assumption that she is probably in a state of hypercortisolemia. So this is like a woman, maybe you're between the ages of like 30 and 55. Maybe you're a new mom, you're a mom of 1 or more kids. Obviously, I don't have to spell out for you, but like the physical and chemical stress of being, and stress, when I say stress, I mean demand, right? So that physical and chemical demand of being pregnant, the physical and chemical demand of labor and delivery, the physical and chemical demand of breastfeeding, the physical demand of sleepless nights, the we'll say financial hit to your career, because you're probably at home. If you're in the States, maybe it's 6 to 10 weeks, depending on your employer. In other parts of the world, that maternity leave can be, a year. In Canada, it's a year to 18 months. And you can have, depending on the company, like 50% of your wages are paid for during that year or up from there. And of course, there's parenting challenges, there's relationship challenges, there's all the other things that are still going on while you're raising this little human. And this is kind of where hormonal derangement tends to start, right? And it leads to some of these other issues that we've been discussing, the PCOS, the estrogen dominance as well. So let's, I want to jump to leptin, because this is something I wrote about this in my book, in the Betty Body. I talk about this with my practitioners in the Estima certification program. And this is kind of the single biggest area, or one of the biggest areas where we see a difference or a bigger challenge for long-term fasting for women. And for women, for any given measure of obesity, as a function of BMI, women have a bigger swing in their leptin response. So very quickly, leptin is a hormone secreted from the adipocyte. It's basically a satiety signal. It tells your brain that you're full. With fasting, which is, in most cases, either a model of caloric restriction, like I was describing in that caloric liquid fast, or it's like a non-caloric liquid fast where you're just having black coffee, water, tea. Women will hit that point sooner of getting hungry versus their male counterparts. Okay. So females who are overweight will display sort of a cluster of symptoms that are consistent with this idea of leptin resistance. And that makes sense, again, from an evolutionary standpoint. We have a higher baseline of adipose tissue than our male counterparts do because we need that excess adiposity to support a menstrual cycle in our reproductive years. As we age, we have a decline in our sex hormones, with testosterone in particular. And if we're not, let's say, engaging in regular, here it is again, resistance training, or there's like a defined strategy, let's say, to put on lean muscle mass, we can become sarcopenic, osteopenic, frail, and brittle. And we will, over time, net become fatter. And I don't mean this in like a fat phobic or anything like that way. I just mean that our percentage of fat is going to go up. Sarcopenia, by definition, is the fatty infiltration of the muscle. That is something you do not want. You want the muscle to be muscle, and you want the fat to be fat. Okay. We don't want the fat in the muscle. It's nice when you're going out for steak, right? Like it's nice when you're, getting that nice marbled steak or what have you. Like that's sarcopenia. That's like that marbling that you see. We don't want that on the human frame. Okay. And please don't write into me about animal cruelty issues. I like my steak. I like it marbled. I don't want it on my women. Okay. I don't want it on my humans. And of course, where we differ from men in terms of fasting is women in general, when we're fasting, our leptin levels can rise up to 3 to 4-fold higher as a function of BMI. So it doesn't matter, let's say, when we compare male and female counterparts, if we kind of equate them for BMI, the leptin levels in the women are going to rise 3 to 4 times higher. Okay. And so when we think about leptin resistance, so I just want to explain this for a minute because it acts very similarly to insulin resistance. So we expect in a normal individual, you eat some food, hopefully it has some protein, has some fat, has some carbohydrates, and then your body will sort of, you will have that signal that, okay, I've taken in enough calories. Like we can go into the protein leverage hypothesis. We can talk about, a protein first approach, let's say, where your body will basically scour the food that it will sort of evaluate the food that you're taking in. And if you don't have enough protein in it, particularly in the first meal of the day, you're going to increase your calorie consumption over the course of the day, and you will overconsume carbohydrates and you will overconsume fats as well. But let's just pretend that you're having like a perfectly balanced, ratioed meal. You're consuming food. Normally, what should happen is the adipocyte will pick that up and say, "Okay, I've had enough protein. There's enough fats in here to keep me making all my fat-soluble vitamins and give me great skin and all the things, enough carbohydrates, all the things. So I'm going to release leptin, and then that's going to be picked up in the appetite regulation centers in the brain. And your brain is going to be like, she's full. And what is the behavior that follows that? You put the fork down. You stop eating. In a leptin resistant model, you will continue to consume food. So even though you might have, let's say, excess adiposity, maybe even if you're overweight, for whatever reason, there is a resistance to picking up leptin in those appetite regulation centers in the brain. So that leads to an increased caloric intake, increased food cravings, overeating, of course, which is going to, when we are continuously over a long delta, taking in more calories, weight gain ensues. And then as you gain more fat, the number of fat cells are going to increase, as do leptin levels. So our leptin levels are increasing and increasing and increasing, and yet we continue to overeat. Okay. So this is important for women to understand, because our serum leptin levels, I'll say it this way. The observation that serum leptin is not related to energy expenditure rates suggests, at least, that leptin regulates body fat predominantly by altering our eating behavior rather than, calorigenesis. Let's say it that way. Okay. Everyone's favorite butterfly-shaped organ. Let's move on to the thyroid. Okay. So the other thing that I see, and I'm hopefully at this point, if you listen to the first lecture and you're listening now, there is, if you are engaging in too much fasting, too often, and too aggressive, it is this hormone, endocrine organ, I should say, that is going to be affected. And most often what I see is for women who are aggressively fasting, what we tend to see when we're kind of looking at thyroid panels, like if we're looking at blood work, is an increase in something called reverse T3. Now, reverse T3 is basically, I like to tell my patients it's kind of like junk T3. It's sort of like kind of the mirror opposite of the active hormone T3, but it doesn't really do much. It is a feedback loop. It is a feedback mechanism. And when you're aggressively fasting, when you are suppressing your insulin levels for too long, this can contribute to an increase in reverse T3, which of course is going to contribute to suppression of thyroid function. One of the things that is kind of classic, or a side effect, let's say, or a clinical indicator of an elevated reverse T3 is a decrease in body temperature and always feeling cold. Like if you're always cold, like you're cold in the summer, let's say, or you always are wearing like sweaters and all of that, your reverse T3 might be elevated. So we want to be thinking about how we can support the thyroid. I believe I've done other podcasts. I know I've done other podcasts on the thyroid. So we'll make sure that we link them in the show notes for you to have a look at. But one of the things I like to always make sure that I am myself consuming, as well as my patients, are high selenium and high iodine foods like salt. Salt is very important. So for me, like I'm Portuguese, so, I love me some sardines. So sardines, one of my favorite ways to get high selenium foods. Brazil nuts, the heavyweight champion, we'll say, of high selenium foods. And of course, if you can stomach liver, that's also great as well. I cannot do that. I will be very open and honest with you. So I do have the capsules, like the liver capsules, or I really like liverwurst. I have found that liverwurst and me are very good friends. So I like liverwurst, which is basically kind of like a liver pate with, sometimes there's heart and like other spices and stuff in it as well. Now, some people have a high reverse T3 even when they're not calorically restricted. Okay. So that implies that the thyroid issue may have more to do with the suppression of insulin itself than it does with the restriction of calories. And of course, as it usually goes, this is way more common in women than it is in men. I would say that if you, at least the patient population that I have seen, this is happening in at least like, call it 30 to 40% of women, where we are seeing aggressive fat, like the suppression of insulin, let's say, or if the other population, like they've been doing keto for too long. You've been doing the ketogenic diet for like years and years and years. And we see this like chronic suppression of insulin, which leads to this elevated levels of reverse T3. It's like, I call this like the deadly triad. I talk about this with my doctors in Estima certification. It's kind of like this deadly triad of a woman who is aggressively fasting. She's doing way too much cardio. Like she's at Orange Theory and she has her Peloton bike and she has all the things. And she's doing keto, let's say, or some form of caloric restriction. And she's doing, in her attempt either to lose weight or, to look a certain way. It's kind of this like orthorexic type of behavior that leads this sort of cluster of these sort of three things, like over cardioing, over fasting, and then overly calorically restricting is often where we start to see suppression of thyroid function. And the other classic for me often as well is a woman who's like, let's say she's doing Peloton or whatever it is, Orange Theory. And I'm not trying to throw shade at these particular companies. It's just that those are the two that I hear the most. So I'm using them as examples. Certainly there are other apps and there are other programs where people are doing, high intensity interval training far too often. Okay. So this kind of gets into a conversation of like, when we are doing our cardiovascular work, which is important, what zone should we be training in? Most women are, working way too hard. They're doing it 4 or 5 times a week. They're probably in zone 5 or 6, and they're in zone 5 or 6 for like 40 minutes to 60 minutes, 4 times, 5 times, 6 times a week, which of course is going to drive up that cortisol. We were just talking about cortisol before. This is kind of paired in with it as well. If you're driving up, that is an adaptation that your body's like, why are we running from a tiger 6 times a week? Like why is this output necessary? I'm much more a fan, and I've spoken about this before in an episode that I believe is entitled Chronic Cardio, which we'll also link in the show notes for you. But zone 2 and zone 3 is kind of where I like to keep. And I would say preferentially, if I had to pick between those two, zone 2 is where I preferentially like to train. If I'm doing any cardiovascular work, it's going to be in zone 2. When I'm lifting, I'm certainly in zone 2 as well, because that's kind of where life happens. Life happens in zone 1 and zone 2, right? We walk, we stand, we like run, we rush to get, we kind of trot, let's say, to catch the bus or, to get in line or to walk faster, like to pass someone on the sidewalk, life happens in zone 2. And I feel like if we're training, hopefully you're training to look better, to change your body composition, to change your metabolic and your physiological health, but you're also training to get better at life, right? Like you're also training so that you don't have to ask somebody to help you lift something or open a jar or get up off the floor. You can get up off the floor unassisted, right? Like hopefully the training in your exercise program is to help you be better at life right now. And also, again, taking that longer lens, for you to be better at life when you're 20 or 30 years from now, right? Because that's going to happen. We're going to be 20 or 30 years older. And, we might as well start training for that now. So fasting aggressively, not a huge fan for the thyroid. So again, one of the ways that I will typically counsel someone if they do have if they do have low functioning thyroid is to easy does it and slowly does it, right? So we don't want to change all the things all at once. The thyroid is usually the last organ, at least I've observed this, like it's sort of the last thing to go. So it's not like your thyroid wakes up and it's like, I cannot handle these conditions, I'm gone. Like on day one, like it takes a couple of decades for the thyroid to be like, listen, like we got to talk because this environment is not acceptable anymore. So with a woman with Hashimoto's, there's or low functioning thyroid, I'll say, there's a couple of different options. Usually I'll start with changing her nutrition. I'm usually not going to get her to fast any kind, like if we already have lab work and I see that there's an elevated RT3, we're usually not going to do much fasting. Like it's going to be like a 12-12. If that, it's like something that's nice and easy. It's not a big hormetic stressor on the body. And we're usually going to start with her nutrition. So I usually have two approaches that are like polar opposites of each other when it comes to thyroid, and they both work marvelously well. There's a bit of an art in terms of figuring out who is going to do better with what, but it's either full on carnivore where we are, and this is usually the woman that has like thyroid antibodies. She has like a whole set of like deranged digestive issues, leaky gut. She has maybe some parasites, H. pylori. Like there's a whole sort of clinical picture that I'm kind of looking for. But I'm either putting her on a therapeutic, so short-lived carnivore diet, or I'm going to follow more of the Terry Wahls protocol, which is like, the polar opposite of carnivore, which is like 9 colors, all the colors of all the vegetables, an appropriate amount of protein and fat. But there are different sort of constituents in terms of which clinical, we'll say manipulation I'm going to follow. Okay. So with that, this is one of my favorite pictures. All these ladies in I would call this maybe the 40s or 50s. I love these bathing suits. I hope that over the last 2 weeks, I've been able to demonstrably show you that women have a much more complex hormonal environment, that we are much more sensitive to changes, let's say, in our environment, in our exogenous consumption, like, our response to foods, when we're fasting. We have, more moving parts and fluctuations that are, supposed to occur cyclically that don't necessarily happen in our male counterparts. And of course, we talked about this last week, that there's certainly a bias with studying men, right? So there isn't, it's getting better, but our culture's love and unfortunately sometimes obsession with randomized controlled trials and trying to tease out all the variables, I think has led to a real hole in the literature surrounding females. I'll say that it is getting better. We are starting to see more and more research that is just female focused, because we are starting to wake up to this idea that we are not little men. For women with PCOS, they responded just beautifully to fasting, kind of all kinds, until we sort of get that metabolic train, until she's, we start to see her healing. For women with estrogen dominance, really, really like a sort of a gut and liver evaluation, sort of that caloric liquid fasting, particularly in the luteal phase of her cycle. For my women who are chronically stressed and inflamed, we don't want to be adding more stressors. So again, like a nice, gentle fast for her. Same goes for thyroid. Women with low functioning thyroid, the fasting is not the place to start. It's usually the last place that we tweak if all the other variables that we've manipulated have not been working. And like I said, with my thyroid patients, it's going to be food that we start with. So I hope that you have found this really useful. And I'm just going to stop my share here and come back. There we go. Hello. So I hope that you found this useful. I would love to hear your feedback, your comments. We try to read, we do read every single review that comes in worldwide, whether that's coming in from the US, Canada, Europe, Oceania, all the places we read them. So would love to hear your feedback. Next week, I've been working on preparing an AMA. So I had posed some questions out to my Instagram followers, got a ton of questions. And so I am currently preparing to have a little nerd sermon with you on that. So that should be coming next week. And until then, I hope you have a great one. And I hope that you've gained a little bit more insight into why we always want to be very gentle with our fasting protocols as it pertains to ladies. With that, I bid you adieu, and we'll see you next week. In this next video, Dr. Sarah Gottfried and I are talking about keto for women and why it is exquisitely different for us. We are talking in this next video about the testosterone advantage, cortisol, and the way that you can do keto right as a woman. Click over here and I'll see you there.
It's not a blanket statement that keto is good for everyone. I want to be sure that comes through loud and clear, because we have to personalize